Hello everyone, this is Dr. Humanis welcoming you all in the series of how to approach. The topic for today is azotemia. So azotemia is nothing but, as you know, there is a patient comes to you with a raised urea and creatinine. Okay, so what you do, how you approach. First thing you have to do is renal ultrasound and urine analysis. In the renal ultrasound, why you need to do is because you have to first rule out the hydronephrosis because it's easily treatable. Okay, so if there is hydronephrosis in the scan, then you send for urological evaluation and relieve the obstruction. The patient will be fine. But in the renal ultrasound, there is no hydronephrosis. Then you have to see what the renal size, parenchyma, and the urine analysis. And if there are small kidneys, thin cortical thinning, bland sediments are there, azotemia, in which the kidneys are not able to concentrate the urine, and if there is a 24-hour uroprotein excretion less than 3.5 grams, then the diagnosis becomes chronic renal failure. And as you know, in chronic renal failure, what you do is symptomatic treatment and delay the progression. So like if there's anemia, you treat the anemia, hypocalcemia, hyperphosphatemia, etc. You treat the same. And if there is end-stage disease, you have to prepare the patient for dialysis. Now, if the in the scan the renal size and parenchyma is intact, if it's normal, then now the diagnosis become acute renal failure. So now you have to rule out it's a pre-renal or the renal cause. So for that you have to see the urine analysis. If the urine analysis are normal, then what you do is urine electrolytes. Okay, so in urine electrolytes, if the fraction of excretion of sodium is less than 1%, and if the urine osmolarity is more than 500 milliosmoles, then the diagnosis become what? Pre-renal azotemia. The causes are listed here. So like dehydration, volume contraction, cardiac failure, vasodilatation, drugs like NSAIDs, AC inhibitors, ARBs, tacrolimus, etc., and renal vasoconstriction, impaired autoregulation, etc. And if the sodium excretion is more than 1% and urine osmolarity is less than 350 milliosmoles, that means there is a problem in tubules. So that now the diagnosis become what? Acute tubular necrosis. So as you know, this is the most common cause of renal AKI. Okay, now if this is if the urine analysis is normal, but if the urine analysis is abnormal, it can be, if suppose there is a muddy brown cast, amorphous sediments and proteinuria, even in that thing the diagnosis is acute tubular necrosis. You have to know that acute tubular necrosis, the urine analysis may be normal or abnormal. So now another abnormalities can, if we find a bacteria, the diagnosis is pyelonephritis, and you have to treat the infection by antibiotics. And if there is a eosinophilic cast, WBCs, then the diagnosis is interstitial nephritis. If there are RBCs, it's renal artery or vein occlusion. In that thing you have to do the angiogram to confirm it. And if there are RBC cast, which is nothing but dysmorphic RBCs, that means there is a problem in glomerulus and there is proteinuria. So we have to do the renal biopsy and to see if it's glomerulonephritis or vasculitis, immune complex mediated, or anti-glomerular basement membrane disease, which is nothing but Good's Pasteur syndrome. Thank you.